Welcome to Medicine Made Easy, your go-to destination for simplified medical knowledge and insightful discussions. Optimizing maternal thyroid function during pregnancy remains a balancing act. This video explores recent guidelines and best practices for managing hypothyroidism in your pregnant patients. A 33-year-old woman, Ms. S., is currently taking 50 micrograms of levothyroxine, LT4, daily. She's on treatment since 6 years. Had history of radioiodine ablation. Her most recent TSH level was elevated at 9.2 ml/ml, and she recently discovered she is pregnant through a home pregnancy test. Before solving the case, let's discuss about hypothyroidism in pregnancy. Hypothyroidism in pregnancy, prevalence and screening. Overt hypothyroidism, OH, elevated TSH, reduced free T4. OH is responsible for the majority of cases of hypothyroidism in pregnancy. The impact of OH is more significant with respect to fetal-maternal outcomes. Subclinical hypothyroidism, SCH, elevated TSH, normal free T4. The combined prevalence of hypothyroidism, both OH and SCH, may reach up to 4 to 7% in a specific population. The effect of SCH on fetal-maternal outcomes is less well-defined. Screening guidelines. Majority of the guidelines do not recommend routine screening of TSH in the first trimester of pregnancy. Rather, at-risk screening may be more suitable in low- and middle-income countries. Etiology and prevalence of overt hypothyroidism, OH, in pregnancy. OH affects approximately 1 to 2% of women in the reproductive age group. OH diagnosed during pregnancy is unusual, but can be present in 0.3 to 0.5% of screened women. The prevalence is often higher in moderately iodine-deficient regions and can be as high as 4%. Factors contributing to the development of overt hypothyroidism, OH. Autoimmune thyroiditis. Autoimmune thyroiditis, such as Hashimoto's thyroiditis, is a common cause of OH during pregnancy. Iodine deficiency. Iodine deficiency is a significant factor behind the development of OH, especially in moderately iodine-deficient regions. Post-surgical hypothyroidism. OH can result from post-surgical hypothyroidism, requiring proper preconceptional care for affected patients. Adverse effects of hypothyroidism on maternal and fetal outcomes. Maternal complications. Spontaneous abortion. Preeclampsia, eclampsia, gestational hypertension. Placental abruption. Preterm delivery. Postpartum hemorrhage. Fetal outcome. Low birth weight. Low intelligence quotient, cognitive impairment. Small hippocampal volume, decreased memory. Death. Factors affecting maternal and fetal outcomes in hypothyroidism. Degree of hypothyroidism. The higher the TSH, the more likely adverse outcomes can occur. Duration of hypothyroidism. A longer duration of hypothyroidism before the initiation of therapy can impact pregnancy more adversely. Treatment status and follow-up. Regular follow-up and proper treatment status are crucial for positive outcomes in hypothyroidism during pregnancy. Screening for thyroid dysfunction. Universal screening controversy. The universal screening of asymptomatic pregnant women for thyroid dysfunction during the first trimester of pregnancy is controversial due to insufficient data showing a benefit of thyroid hormone replacement. Targeted approach. Preference for a targeted approach to screening, focusing on pregnant women with specific risk factors or symptoms of hypothyroidism. First question is whom to screen. Criteria for screening. Pregnant women living in areas of moderate to severe iodine insufficiency with symptoms of hypothyroidism or with a family or personal history of thyroid disease are candidates for screening. Additional considerations. Screening is also recommended for women with specific conditions or histories, such as thyroid peroxidase, TPO, antibodies, goiter, age over 30 years, or type 1 diabetes, recurrent miscarriage or preterm delivery. Multiple prior pregnancies, 2 or more. Morbid obesity, body mass index, BMI, greater than or equal to 40 kilograms per square meter. Infertility. Prior thyroid surgery. Laboratory findings. Thyroid physiology changes. During a normal pregnancy, there are changes in thyroid physiology, leading to altered thyroid function tests. These changes should be interpreted using population-based, trimester-specific reference ranges for TSH and assay method. Interpretation challenges. Challenges in interpreting thyroid function tests due to population differences in the TSH upper reference limit and the need for trimester-specific reference ranges for free T4. Let's dive deep into the topic. You can watch our previous topic on hyperthyroidism in pregnancy. The link is provided in the description. Approach to a patient with hypothyroidism in pregnancy. Go for thyroid profile. If TSH values are high and free T4 levels are decreased. Diagnosis is overt hypothyroidism. Treat with thyroxine urgently. Your goal in treating is to normalize TSH levels as soon as possible. If target achieved, then close follow-up with TSH monthly is required. If TSH levels are increased and free T4 is normal. It is subclinical hypothyroidism if TSH levels are more than 10 mIU per ml or upper level of normal, i.e. more than 4 ml/ml, then it is overt hypothyroidism. If TSH levels are 4 to 10 mIU per ml, treat with thyroxine. Target of TSH should be less than 2.5 ml per milliliter. If TSH levels are between 2.5 to 4 mIU per ml, advise anti-TPO antibodies. If antibodies are positive, give low dose of thyroxine. If antibodies are negative, then observe. Repeat thyroid profile frequently. Management of subclinical hypothyroidism in pregnancy. Threshold for treatment. The ATA guideline suggests a treatment threshold of 4 mIU/L for subclinical hypothyroidism in pregnancy. Antibody status. Antibody status and other significant parameters, recurrent pregnancy loss, IVF pregnancy, are important in decision-making for the treatment of subclinical hypothyroidism. Impact of treatment. The beneficial impact of treatment on pregnancy outcomes should be weighed against the potential adverse effects on the fetus. Management of pre-existing hypothyroidism. Preconceptional TSH levels. Women with pre-existing hypothyroidism may require an increase in the LT4 replacement dose, particularly in the first trimester of pregnancy. Empirical dose increase. An empirical dose increase of 30 to 50% is recommended over and above the ongoing dose of LT4. Postpartum progression. Some women may need a higher LT4 dose following delivery due to postpartum progression of autoimmune thyroiditis. Post-pregnancy adjustments. Postpartum considerations. Assessment and necessary adjustments to thyroid hormone levels after delivery, with a focus on maternal and infant well-being. Thyroid peroxidase antibodies. Management and monitoring of euthyroid women with thyroid peroxidase antibodies to mitigate potential risks during and after pregnancy. Management of newly diagnosed overt hypothyroidism in pregnancy. Initial LT4 dose. A higher starting dose of LT4 is often required in this scenario. Retrospective analysis. Initial levothyroxine dose of 2.33 plus or minus 0.59 ug/kg per day. A significant percentage of patients reached the TSH target. Increased surveillance. Increased surveillance for maternal hypertension, preeclampsia, and fetal growth restriction is recommended in such cases. Because in previous slides we discussed that hypothyroidism associated with various adverse effects on pregnant mother. Management of inadequately treated hypothyroidism. 1.6 to 1.8 micro-GMS per kg is the initial levothyroxine dose. An initial levothyroxine dose of 1.6 to 1.8 ug/kg/day is recommended for women with inadequately treated hypothyroidism entering pregnancy. Coming to the starting of the topic, we discussed about a case. A 33-year-old woman, Ms. S., is currently taking 50 micrograms of levothyroxine, LT4, daily. She's on treatment since 6 years. History of radioiodine ablation. Her most recent TSH level was elevated at 9.2 ml/ml, and she recently discovered she is pregnant through a home pregnancy test. Case scenario: pre-existing hypothyroidism. Management approach. Given the patient's history of radioiodine ablation and current TSH level, it appears her hypothyroidism is inadequately controlled entering pregnancy. Therefore, a prompt medication adjustment is necessary. Increasing the dose to 100 micrograms per day would be beneficial. Regular monitoring of thyroid levels also very important part. Repeat thyroid profile after 4 weeks. Thank you for watching. If you're interested in any particular topic, please let me know in the comments section below. Please like, share, and subscribe for more content.